I'd also like to apologize because I had a misconception that this surgical pulse was going to be in the next week, in the coming week. So I was quite unprepared until a day earlier. So excuse me for my less than normal quality slides. So the topic which I was given was treatment of carcinoma, CA prostate and recent advances. In next 15 minutes, it will be quite hard for me to cover all the aspects of carcinoma prostate and recent advances. And given the fact that most of the crowd comprises PG residents, are dealing only on the important aspects of management of CA prostate. So we all know that carcinoma prostate is the most common non-skin cancer in the United States. This is the data which I have taken from Campbell's. And it's the second leading cause of cancer death in the United States. Second leading cause of cancer death. The important point is that most of the prostate cancers are indolent, they are not aggressive. So most of the patients who has a prostate cancer would die with prostate cancer rather than dying of prostate cancer. So which is why only 3% of prostate cancers die of the disease. They would rather die of natural cause than of the cancer itself. So what then is the histology of prostate cancer? All of us know and agree that it's adenocarcinoma. Rare histological findings include urothelial CA, sometimes neuroendocrine differentiation of adenocarcinoma, sarcomas. But then adenocarcinoma is by far the most common. The important histological point which I wanted to highlight is that prostatic epithelial cells stain positive for prostatic acid phosphatase and PSA. PSA is an important marker of CA prostate. Prostate cancer never has a basal cell layer, whereas normal prostate gland has a basal cell layer, and the basal cell stands positive for high molecular weight keratin, which is why when there is a confusion between whether it is a prostate cancer or a normal gland, we can stain for SMWK. Just a good to know information. And we all know from our basic MBBS that most of the adenocarcinoma prostate arises from the peripheral zone. Only a minor percentage arises from the periurethral transitional zone and from the central zone. So what are the symptoms and signs of this disease? So if you want to say that I can cure someone of prostate cancer, the patient must be asymptomatic. What I mean to say is, if the patient is symptomatic or has some signs, the disease is more or less incurable. So a disease which can be cured will usually be diagnosed by screening. So in early stage, there are no symptoms. Locally advanced cases, they can present with features of voiding LUTS, like obstructed voiding, poor stream, sometimes even renal failure. So you might get a viva question in your final MS exams. What is the cause of renal failure in CA prostate? You have to say that it's growth towards the trigone and obstruction of both the ureteric orifices. Some patients can present with hemospermia. So a patient about 40 years who presents with hemospermia has to be evaluated with a serum PSA. Impotence and decreased ejaculate volume are other important signs of symptoms of locally advanced disease. Metastatic disease, we all know that prostate cancer usually spreads to the lumbar vertebra and to the long bones. So bone pain, pathological fractures should always alarm you that the patient might be having metastatic CA prostate. Similarly, anemia, lower limb edema. If you have asymmetrical lower limb edema or edema in the both lower limbs with big lymph nodes in the immural area, always think that the patient might have CA prostate. Do a rectal exam, send serum PSA. So lower limb edema, you can every now and then encounter patients with asymmetrical lower limb edema or even bilateral lower limb edema with obstructive voiding symptoms. Think of CA prostate. Sometimes retroperitoneal fibrosis, DIC, and even paralysis. So, as I already mentioned, CA prostate is one of the most common diseases in the Western world. So how do they diagnose? They diagnose by screening. So the term screening is used to test for disease among those people who are asymptomatic. Whereas we use the term diagnosis when we find disease among those patients who are symptomatic. So by screening, we are trying to find disease among asymptomatic individuals, thereby trying to lower the mortality of the disease. So 2 large trials were conducted in the West, the PLCO trial in the United States and the ERSPC trial in Europe. The PLCO trial unfortunately did not show any survival advantage by screening with PSA and DRE for CA prostate. On the contrary, the European trial, the ERSPC trial, did show some mortality reduction after 13 years. The number needed to screen was 781 patients and the number needed to treat was 27 patients to reduce 1 mortality. So herein lies the sad part of screening. Whereas we can reduce mortality, we can also cause a significant overdiagnosis, and more important than that, we can cause overtreatment. As I already mentioned in the beginning of my slides, most of the cancer prostates are indolent, they are not that aggressive, so most of the cancer patients will not die of prostate cancer. So screening for prostate cancer might lead to overdiagnosis and overtreatment and might lead to complications and reduce the quality of the life of the patient. So this fact has to be taken into consideration. How is screening done? It is done by estimating the serum PSA and doing a digital rectal examination. What about transrectal ultrasound? Transrectal ultrasound is not used for screening. It is not used for diagnosing prostate cancer. Okay? For screening prostate cancer, we use just PSA estimation and doing a good quality rectal exam. And because by doing screening, we're trying to find patients at early stage whom we can cure. Where in general, we don't do screening for those whose life expectancy is less than 10 years. If you have a patient who is not going to survive more than 5 years, you don't do PSA screening for these patients. So how frequently should PSA screening be done? Different guidelines say different things. Every 1 to 5 years. It has to be done annually for high-risk patients and less frequently for low-risk patients. Excuse me for this typological error. For instance, if the median PSA value for 40 to 49 years is regarded as 0.6, if it is more than 0.6 for an age group, for an individual who is 45 years, let's say, then it has to be done more frequently. The PSA estimation has to be done annually in such cases. And PSA predicts the risk of cancer prostate, but it actually doesn't diagnose CA prostate. Now we have to know an important fact. PSA is organ specific, that is, it is specific to prostate gland. It is not disease specific, meaning PSA can get elevated in BPH, it can get elevated in UTI, it can get elevated in acute prostatitis after a vigorous prostatic massage, cystoscopy. So PSA is organ specific, it is not disease specific. There is no particular threshold at which can trigger a biopsy in patients with elevated PSA. So when to biopsy in case of CA prostate? When we have suspicious rectal examination, when the PSA is abnormal, so age and ethnicity adjusted, a free PSA less than 10%, and currently, earlier it used to be told that PSA value more than 4 nanogram per ml would trigger a biopsy. Currently, it's been decreased to up to 2.5 or 3. So in the ERSPC trial, PSA value more than 3 triggered a biopsy. So there are other parameters like PSA velocity, increasing PSA by more than 0.35 nanogram per hour if the PSA is less than 4, and PSA velocity more than 0.5 if PSA is more than 4. And in those patients who are taking finasteride, if the PSA doesn't decrease by 50% after 1 year, remember in patients taking finasteride, you should always estimate repeat PSA after 6 to 12 months, and the PSA levels should decrease by 50%. So if the initial PSA was 4, after 6 to 1 year it should be 2. If it is not 2, then you have to do a prostate biopsy. Other important factor is the PSA density measured by dividing the PSA by volume of the gland. If it is more than 0.15, that's an indication for doing a biopsy. So there are certain instances where the initial biopsy comes negative in spite of raised PSA, and you have to do a rebiopsy again. So indications for doing a rebiopsy are a rising or persistently high PSA, again a suspicious rectal exam. When there are certain things in the histology like a typical small acinar proliferation, high-grade pain. These are the conditions where you might have to do a repeat biopsy. Again, when the initial biopsy is negative and the PSA is still high, it's always wise to obtain a multi-parametric MRI. Remember the word multi-parametric, a multi-parametric MRI prior to doing a repeat biopsy. Multi-parametric MRI is currently available in our country as well. So prostate biopsy should always be an ultrasound-guided biopsy. It can be transrectal ultrasound-guided or transperineal ultrasound-guided biopsy. Between 4 to 10 percentage free PSA calculated by estimating the free PSA and total PSA and taking the ratio will help us guide biopsy. So if the percentage free PSA is less than 10%, we need to do a biopsy, 10 to 15%. So these are the guidelines given in European urology. So I don't think I'll be speaking on this. Regarding rectal examination, we have no consensus in what is actually abnormal. By doing a rectal exam, we are trying to assess not only the size of the gland, but also the presence of nodules, any asymmetry, induration. Any suspicious rectal exam findings should be proven with a biopsy. So when to biopsy in case of CA prostate? When we have suspicious rectal examination, when the PSA is abnormal, so age and ethnicity adjusted, a free PSA less than 10%, and currently, earlier it used to be told that PSA value more than 4 nanogram per ml would trigger a biopsy. Currently, it's been decreased to up to 2.5 and 3. So in the ARSPC trial, PSA value more than 3 triggered a biopsy. So there are other parameters like PSA velocity, increasing PSA by more than 0.35 nanogram per hour if the PSA is less than 4, and PSA velocity more than 0.5 if PSA is more than 4. And in those patients who are taking finasteride, if the PSA doesn't decrease by 50% after 1 year, remember in patients taking finasteride, you should always estimate repeat PSA after 6 to 12 months, and the PSA levels should decrease by 50%. So if the initial PSA was 4, after 6 to 1 year, it should be 2. If it is not 2, then you have to do a prostate biopsy. Other important factor is the PSA density measured by dividing the PSA by volume of the gland. If it is more than 0.15, that's an indication for doing a biopsy. So there are certain instances where the initial biopsy comes negative in spite of raised PSA, and you have to do a rebiopsy again. So indications for doing a rebiopsy are a rising or persistently high PSA, again a suspicious rectal exam. When there are certain things in the histology like a typical small acinar proliferation, high-grade pain, these are the conditions where you might have to do a repeat biopsy. Again, when the initial biopsy is negative and the PSA is still high, it's always wise to obtain a multi-parametric MRI. Remember the word multi-parametric, a multi-parametric MRI prior to doing a repeat biopsy. Multi-parametric MRI is currently available in our country as well. So prostate biopsy should always be an ultrasound-guided biopsy. It can be transrectal ultrasound-guided or transperineal ultrasound-guided biopsy. It should not be a finger-guided biopsy. At least 8 to 12 cores should be taken, mainly from the peripheral zones, and we should also biopsy any suspicious areas in the gland. So when you are reading the histology report of cancer prostate, 2 important terms always come: Gleason's Grade and Gleason Score. So what is Gleason Grade? It denotes the architectural pattern of prostate gland. Remember, adenocarcinoma is cancer of the glands. Okay? So architectural pattern of prostate glands as seen in low power microscopy. So we don't use a high power microscope to assess the Gleason stage and score. Cellular characteristics like mitosis, nuclei are not used, and hence you might be asked in exam whether an FNSE is appropriate in CA prostate. The answer should be no, because FNSE gives you an idea about maybe the mitosis, the cellular characters, but it doesn't give an idea about the architectural pattern of the gland. So you should always do a true-cut biopsy and not an FNSE. And there are 5 Gleason's grade, Gleason 1 to Gleason 5. Gleason 1 is large, well-formed glands, well-differentiated, whereas Gleason 5 means no glandular pattern at all, undifferentiated or poorly differentiated. So what then is the Gleason score? So we add Gleason's grade to get the Gleason score. So Gleason score is the sum of the most abundant grade and the second most abundant grade. For example, if the most abundant grade was 3 and the second most abundant grade was 4, the Gleason score would be 7. Excuse me. If only one Gleason pattern was present, then you have to double it. For example, 3 plus 3 is equal to 6. If 3 patterns or grades are present, then we add the most common and the highest grade. That is as seen in this example. So if we have a 70% Gleason's grade 1 and 10% Gleason grade 5, then the sum would be Gleason's score would be 4 plus 5 is equal to 9. Recently, the International Society of Uropathologists has tried to simplify Gleason score by using the Gleason's grade as shown in the slide. So another important factor in management is the T stage. So by T1 we mean disease which is non-palpable. So most of the prostate cancers these days in the Western world are T1C. Okay, T1C, which means that it is a screen detected cancer. PSA screening पछि high भएर biopsy गरेको मा पत्ता लागेको cancer is non-palpable. T1A is after CA prostate detected after TOR, less than 5% of the TOR specimens, more than 5% of the TOR specimen. T1B. T2, you palpate a small nodule, but it is confined within the gland. T3, it has penetrated the capsule. So T3 is extracapsular spread, and T3P is invasion of the seminal vesicles, and T4 means invasion of the adjacent structures. So I talked about the PSA level, I talked about Gleason score, and I talked about TNM stage. So these are the 3 important parameters, these are the three important factors which helps us to stratify disease into low risk, high risk, or intermediate risk for the sake of management. So selection of treatment options for localized disease depends on the risk factors, whether it is low risk, intermediate risk, or high risk, and on the general health of the patient and their life expectancy. So active surveillance, almost similar to watchful waiting, but active surveillance is more active, proactive, is indicated for patients who have life expectancy less than 10 years and who have low-grade cancers. It is also now being evaluated in younger patients with low volume, low or intermediate grade up to Gleason score 3 plus 4 is 7 tumors to avoid or to delay treatment that might not be immediately required. See, the idea is to overtreat the patient, is to avoid overtreating the patient. When you subject patient to active surveillance, TRE and PSA should be measured quarterly or semi-annually, and biopsy should be done 6 monthly or 1 yearly. The drawbacks of active surveillance is that the patient has to live with a constant fear of cancer, and up to 50% of the patients in active surveillance, they can progress. So the window of cure by doing a radical surgery might be lost for them. Radical prostatectomy can be done by open lap or robotic approaches these days. Most commonly it is done robotically. The advantages are that it can be curative, there is very minimal collateral damage, it can provide specimen for accurate pathological staging, and it is always easy to identify treatment failure after radical surgery. They talk about trifecta and pentafecta after radical surgery. Trifecta means trying to achieve biochemical recurrence-free survival, prolonged survival without recurrence, trying to achieve continence of urine, and trying to achieve a good erectile function after surgery. So these 3 combined constitute the trifecta. In the era of robotic surgery, they talk about pentafecta, and you add absence of post-operative complications and negative surgical margins to this trifecta. So how do you select patients for radical surgery, radical prostatectomy? The patients should survive more than 10 years, and the tumor should be biologically significant. That is, maybe Gleason score more than 6, but it has to be completely resectable. If it is not resectable, you should not subject the patient to surgery because he can have complications that can impair his quality of life. Can you use neoadjuvant hormones before surgery? The answer should be no. You should not use hormones prior to surgery. What about post-operative radiotherapy after surgery? You can use post-op radiotherapy in an adjuvant setting if there are adverse pathological findings, if the margin is positive, if there is invasion of seminal vesicles, or you can use salvage post-op radiotherapy, meaning when you use radiotherapy when there is post-op biochemical recurrence. Regarding radiotherapy for localized disease, you can use either, because I'm running short of time, I'll try to squeeze into the limited amount of time which I have. We can use either external beam radiotherapy or brachytherapy. Heavy particle therapy is not used because of increased side effects. Locally advanced disease, as I mentioned before, it is a disease which has gone beyond the confines of the capsule. So it is defined as T3, T4, N plus minus, and M naught. There is no standard treatment. It has to be a multimodal treatment. So either either surgery or radiotherapy combined with systemic treatment, meaning either radical prostatectomy with lymph node dissection with adjuvant radiotherapy plus adjuvant hormone therapy, or hormone therapy or radiotherapy combined with hormones. ADT is androgen deprivation treatment. What about metastatic disease? Metastatic disease is the kind of patients which we frequently encounter in our country. Median survival is just 42 months, and systemic treatment is generally required unless the patient is asymptomatic or wishes to defer castration, or he doesn't want to get castrated. By systemic treatment, we mean some form of androgen deprivation therapy or chemotherapy. So something about androgens. Androgens, more than 90% of the androgens are secreted by the human gonads, and the remaining 10% are secreted by the adrenal glands. So if you look into this diagram, almost all the androgen is secreted by is formed from cholesterol, and drugs like aminobutyramide and ketoconazole would act at this level. Newer drugs like albuterol would act at this level and this level. Okay. So there's certain terms like ADT, medical or surgical castration. Castration can be surgical, meaning we do bilateral orchidectomy, or it can be medical, meaning we use either LHRH agonists or antagonists. So anti-androgens are drugs which antagonizes the androgen receptors, that is, which blocks the androgen receptors. And we have a term called combined androgen blockade, which means that we use, we combine castration with blockade of the androgen receptors. So orchidectomy is the most surest way of obtaining castrate level of androgens. It is permanent. And LHRH agonist, a typical drug is leuprolide. It is given by depot injection. There is an initial flare for 3 to 4 weeks because it's an agonist, and it will initially cause some increase in LH levels, and which then causes an increase in the androgen levels. So it is always to be combined with anti-androgens for the first 3 to 4 weeks. A newer drug, a relatively recent advance, is digavelixagen, which is LHRH antagonist. It is not associated with flare, and we don't have to use anti-androgens. A typical anti-androgen is bicalutamide. With the use of anti-androgens, the LH and androgen levels rise because the testosterone feedback to pituitary and hypothalamus is also blocked. Because the androgen level is normal, potency is preserved, and because there is increase in the level of androgen, it aromatizes to estrogen, so they can be gynecomastia. The other important side effect is liver toxicity, so LFTs have to be done. Enzalutamide, another recent advance, it is also an execute. So there are drugs like enzalutamide and other drugs. I think I'll stop.